Hello and welcome to another episode with Dr. Mohammed Al-Mu'taz. In this episode, I will be touching on the upper GI bleeding management. I will be explaining the following: what to do on assessment, what to start, how to stabilize the patient, what to start the patient on after that, when to arrange for an endoscopy, and what is it that we're looking for, and stabilization after that, and the plan for discharge and follow-up in the clinic. So stay tuned with this episode. And please like and subscribe for further information and further videos such as these for medical residents, students, and anybody who's interested in the medical field and health sector. Before that, let's hit it with the introduction. Let us start with a small story and a schematic video that I've arranged for here.
He was 40 years old, a successful businessman, confident, tough, always under pressure, and always on the go. Meet Khalid. For years, stress was his silent companion. Deadlines, phone calls, meetings. It started as a burning pain in the upper abdomen, a tight, gnawing feeling, especially when his stomach was empty. Nausea, bloating, early fullness, bitter taste in the mouth, pain that improved slightly when he ate, then came back stronger. One morning, he noticed something new. His stool was black, sticky, tar-like. He felt dizzy, weak. His heart raced, just walking to the kitchen.
His blood pressure is 92/60.
Pulse 110.
Conjunctival pallor. He looks pale.
The medical team acted immediately. High-dose IV omeprazole infusion started, 80 milligram bolus, continuous infusion. Kept NPO. Type and cross-match ordered.
Next morning, patient Khalid was taken to the endoscopy unit. We were able to get control of the bleeding from the ulcer. I am going to start you on a medication to help it heal.
I hope you liked that video and you've had a look at it. So without further ado, let us dive deep into what happened. This patient, Khalid, presents to you with hematemesis and melena, which is black tarry stool that's present, and it has a soft consistency. The blood pressure of Khalid was on the lower side, 90/60, which indicates that the patient is in hypotension. Therefore, we need to assess the patient urgently. These patients will probably present in the RR or in the triage as severe cases. Start with your ABCs. So if the patient is actively bleeding, then you want to assess the airway, or if the patient has low GCS or any changes in mental status, then you want to consider intubation for the patient. If the airway is intact, then you move on to the breathing and you assess the breathing. Check for crackles or any signs of aspiration, and then move on to the circulation. In this case, the patient is hypotensive, 90/60, so therefore you want to give fluids. In the meantime, also send for labs so you can have a general idea of how much the HB is. In this case, let's say the patient has an HB less than 7, then you want to consider transfusion. Packed RBCs, usually 2. And if you see the patient actively vomiting and he has a prior history or she has a prior history of any cardiac disease, then let the threshold be a bit higher at around the HB line 9. Patient is probably bleeding from somewhere, and it's usually in the upper GI region. Why? Because of the melena or the upper GI vomiting. Start with omeprazole. Give an 80 mg stat and then consider an infusion for 24 to 72 hours. Why is that? You want to limit the bleeding and you want to control the source. For instance, if there is gastric ulcer, then you want to control. After you've done that, consider the boluses. If you cannot give too much fluids, such as in cardiac patients, then consult cardiology. However, if you can, then give fluids. And after that, make sure the patient goes to an endoscopy. Keep the patient MPO. Do not give foods. In those instances, you keep the patient's MPO and you arrange for an urgent endoscopy, an OGD, within 12 to 24 hours. When you enter through the OGD, you want to assess the whole of the stomach, also the duodenum. You have to find the source of bleeding. And if you do find it, then you want to either administer adrenaline to control the bleeding there, or sometimes they use clips. Whatever it is the gastroenterologist decides on will be done. After all that has been done and the bleeding has been controlled, the patient will usually be transferred to the wards. In the wards, you could repeat the CBC and keep the patient for observation. However, in certain institutions they don't do that, and once everything is well and the patient returns to normal blood pressure and his normal consciousness level, if the patient has been intubated, then you might want to consider extubation, provided the patient's ABGs and the reason for intubation has been resolved. And if the hypotension resolves, the bleeding is controlled, and the patient is well, then the patient can be safely discharged with omeprazole or any other PPI. For instance, pantoprazole. You'd give that 40 mg twice a day for 2 weeks, and then consider changing that to 40 mg once a day for a week. After that, make sure you repeat the CBC within 1 week and see the patient within the next 1 to 2 weeks with the HP. Make sure all has been controlled, and if the patient is fit for discharge, then you can discharge the patient entirely from the gastroenterological system. So that is just a brief idea of how to approach the upper GI cases, and cases are basis on basis. So each patient will be managed slightly differently. However, the schematic of the treatment is as explained. Now, if you've liked the contents of this video, as I've mentioned earlier, please watch my chest x-ray video as to how I explain that. And like and subscribe to my channel for more content such as this. Stay